Infectious keratitis after LASIK is one of the most serious complications of this technique. Fortunately, it is a rare complication. We found an occurrence rate of 1 in 5,000. Since 1993, when we began LASIK surgeries, we have treated 46 cases of infectious keratitis of Argentina and limiting countries. Of these cases, 16 were contaminated with pneumococcus. All of these cases occurred to the same surgeon on one single day of consecutive procedures. This particular random case, which modifies percentages of etiology, will be left aside, and we will focus on the analysis of a pilot study of the remaining universe. Coccus gram-positive, 53.4%. Most frequently found germ was Staphylococcus aureus. At first they appeared as multiple spots with full regular borders. Later the borders became irregular and the spots blended into each other. The means of contamination are skin and eyelid borders. Gram-negative bacilli, 16.6%. Most frequently found germ was Pseudomonas aeruginosa. Infiltrates with irregular borders are observed. Sizes vary according to elapsed time. Contact lenses are the means of contamination. Mycobacterium, 10%. Here we see slow-growth granulomatous infiltrates that are found in different locations of the cornea, or infiltrates with a crystalline appearance, as we see in this case. Surgical instruments are the means of contamination. Fungi, 20%. Aspergillus flavus and Candida albicans are most frequently found. Features are slow evolution thick infiltrates with irregular borders that grow towards the deep stroma. The environment is the means of contamination. We will now describe the flagship case, a female patient minus 5 diopters myopia to which LASIK surgery was performed 30 days ago. She presents spontaneous flap loss, a large, deep, and thick stromal infiltrate with an anterior chamber reaction, hypopyon and thick exudates on the anterior capsule of the crystalline lens. Candida albicans was isolated. Both local and general treatment was started. The response was unsuccessful. We observe a more severe reaction in the anterior chamber and the deeper stromal infiltrate. Here a descent cell with a serious perforation risk. Thus, we decided to perform a conjunctival flap placement. The infiltrate keratectomy. Specific drugs were applied. Scleral graft. Now we see a favorable evolution. A slow shrinking of the conjunctival flap during the next 5 months when we decided to operate again. We performed a corneal transplant. After lifting the cornea, we found and removed crystalline lens adherences, an anterior vitrectomy was performed. The scleral supported posterior chamber lens was then placed. The corneal graft is placed. Here we see the post-op at 1 day. Treatment. Due to the depth of the interface and the difficult accessibility for drugs, we must relift the flap, take culture samples, and wash out with specific drugs according to case features. The drug therapy for each case is the following. Coccus gram-positive, vancomycin, 50 mg per milliliter. Cefacilin, 50 mg per milliliter. Gram-negative bacilli. Ceftazidime, 50 mg per milliliter. Tobramycin, 14 mg per milliliter. Quinolone, 0.3%. Mycobacterium, amikacin, 25 to 50 mg per milliliter. Aspergillus, netamycin, 5%. Miconazole, 2 mg per milliliter. Topic ketoconazole, 1 to 5%. Candida, amphotericin B, 1 to 2.5 mg per milliliter. Fluconazole, 2 mg per milliliter. The most common risk factors are blepharitis, conjunctivitis, contact lens users, dry eye, systemic diseases, immunosuppression, environment, post-op trauma. In conclusion, be careful with patient selection. Control post-op conditions frequently. Generally, symptoms may appear after keratitis. Be very aggressive. Relift the flap, take culture samples, and start specific treatment. If necessary, resect the flap. And remember, the best cure is prevention.